Thank you so much, SK sir, for having invited me in this session. Am I audible?
Yes, Shreyas.
Okay, wonderful. So after the wonderful array of pictures and videos which Dr. Namrata Sharma showed, I'll deal with the specific aspect of complication of recurrent pterygium. So before we go into management of recurrent pterygium itself, what is special about recurrent pterygium? Why do we talk about it so much? More than the primary pterygium itself, which usually is an innocuous condition, just slightly cosmetically bothersome, maybe very rarely visually debilitating. It is a condition where the recurrence is actually worse than the primary problem, which has a more aggressive clinical course. It is more difficult to treat and is best avoided. It can invade the underlying fibrovascular planes, involve the recti, and can cause restrictive strabismus as well. So it's essentially pterygium itself, as I will describe in the subsequent slide also, is a primary elastotic degeneration. Whereas a recurrent pterygium is a completely different and distinct entity, and possibly the very word recurrent itself is a misnomer, because it's not really a recurrence of the pterygium in most cases. Very, very rarely you can have a UV-mediated recurrent pterygium happening over many, many years. But the most common recurrent pterygium is just a fibrovascular tissue, a pannus, which is kind of growing over the cornea, over the limbus. Along with it, it could be accompanied by some degree of limbal stem cell deficiency also. So the recurrence itself is not UV mediated. It is a fibroblastic proliferation. It's essentially a response to the surgical trauma that has been done, and is kind of akin to the histopathologically to that of a keloid tendency, with a kind of fibrotic tissue present in a recurrent pterygium. As already discussed by previous speakers, Bear sclera has the highest recurrence rate. The rates vary widely depending on which article you're quoting. But suffice to say, conjunctival autograft and perfect technique appear to be the best. Perfect technique, however, has not caught on widely because it's kind of a very extensive surgery for a very, very small problem. And therefore, even though recurrence rates are less, it's not really caught on. Conjunctival autograft works extremely well. Comparing conjunctival autograft with amniotic membrane for especially large pterygia or double pterygia, where some may be using amniotic membranes, it is best avoided, as can be seen, because while amniotic membrane is better than not doing anything at all, is better than Bear sclera, still compared to a conjunctival autograft, the risk of recurrence both after primary surgery as well as recurrent surgery is much, much higher. So the causes of recurrence, I mean, I think Dr. Elankumaran has also alluded to this. Any insufficient graft size, thick grafts, a lot of tenon, any tissue retraction, as you can see in this picture, can all lead to recurrence. As Dr. Namrata Sharma also showed, graft inversion is another reason where, if not identified early, can lead to necrosis of graft and can predispose to recurrence. And occasionally you can have these small innocuous peripheral recurrences, which very often the patient themselves may not notice, but we see this on the slit lamp, is essentially because of inadequate peripheral excision of the conjunctival tissue of the primary pterygium, and that leads to a focal small recurrence. Usually can be left as it is, and no major intervention is required. Recurrent inflammation has been spoken about, and that's a major problem. And if there is a inflammation either because of excessive surgical manipulation or a young patient in an inflamed pterygia, all this can cause. So these are all essential factors to a conjunctival autograft. I will go on to the management itself. So CAG continues to be the best. You can combine it with a limbal autograft, or you could do a mini slet. The advantage of a mini slet over a limbal autograft is you can take a smaller amount of limbal tissue. Along with that, if there is excess area which is uncovered, which you have not covered with the conjunctival autograft, you could combine it with an AMT, though I would not suggest AMT as the primary procedure. So it's just one video which I'll show of a recurrent pterygia which had already been operated twice earlier in another center, and the patient came back with a third recurrence. So one thing with regard to dissecting a recurrent pterygia, how it differs from the primary pterygia, is that getting a plane can be a little more difficult. The normal plane, which is very, very easy to get in a primary pterygia, because of the extensive fibrovascular proliferation, the normal plane is lost. So you may have to be a little more meticulous in your dissection. You can encounter more bleeding. Adequate cautery is necessary. And then while peeling off the cornea, now peeling a primary pterygia will come off in one go, whereas a recurrent pterygia has a little more addition because it's a fibrovascular tissue, and it is kind of akin to dissecting a pannus following a chemical injury. So you may have slightly different planes, and you will have to meticulously dissect it out and ensure you leave behind a very smooth and even bed. You can take conjunctival tissue from the same eye or the other eye, especially if it has been operated 2 or 3 times before. The conjunctiva in the same eye might be very, very fibrotic superiorly, and you may not be able to harvest it very well. And it's important that we get a very generous, large graft to cover the entire area to prevent subsequent recurrence. Here, I'm just combining it with a small mini slit, as this recurrent pterygia had involved almost 5.5, 6 clock hours of the limbus. So I'm just taking a small amount of limbal tissue also, about half a clock hour of limbal tissue. And I will close the primary area of defect. And then I will place the large conjunctival autograft. And my preferred technique in these cases, when I'm doing a large AMG or a conjunctival autograft, is instead of applying the glue primarily, I prefer to place the tissue, fold it in half, apply the glue. This way, you don't have much excess glue and the tissue doesn't float over it, and it is actually well opposed and well adherent. And then subsequently, you can place your slit pieces on top of it, and then glue it together and place a bandage contact lens. And you can provide excellent outcomes with just minimal scarring because of the primary surgery. Adjuvants are available for recurrent pterygia as well as primary pterygia, more useful in recurrent pterygia. I'll quickly run through them. Mitomycin C has been around forever, and it has been used intraoperatively and postoperatively, though intraoperatively is more common. It does reduce recurrence rates in both primary and recurrent pterygia, but complications with mitomycin C are well known, and you can have scleral melts, delayed epithelialization, and the subsequent problems of delayed epithelialization. 5-FU, both topically and subconjunctivally with varying doses, has been used. Reduction in recurrence is controversial. It's not been found to be very effective. Side effects are lesser than mitomycin C. It is, however, epitheliotoxic. Bevacizumab has also been used because of the VEGF overexpression in recurrent pterygia. It is well tolerated, minimal side effects, but as we know, it requires multiple injections. There is a cost to it and recurrence after stopping the injection. So in conclusion, a meticulous dissection is necessary. You need a large donor graft size, which is properly fixated with either glue or sutures, and judicious use of adjuvants, though adjuvants are not really necessary if a good dissection and good graft has been adequately fixated. And prevention is definitely better than cure in this case. Thank you so much for your kind attention.